So perimetry, it is the systemic measurement of visual field functions, or the science of measuring the visual field is called perimetry. So there are a number of definitions, but all are the same. Like perimetry is also the measurement of visual functions of the eye at topographically defined loci in the visual field, or it is a procedure for measurement of individuals' visual field, what they are able to see peripherally as well as centrally. All definitions the visual field welcome. So we should also, so before perimetry we should know about the visual field. So as you know that perimetry is the measurement of visual field, so we should know visual field first. Visual field is defined as the part of the environment that is visible to the steadily fixing eye. The extension of visual field is shown in this diagram. So visual field, it is also known as hill of vision. The visual field is the extent of an area visible to an individual during steady fixation of the eye in any one gaze or direction. Harry Trocker defined it as island of vision surrounded by sea of blindness. So if this is the island of vision and this is the surrounding blindness which we cannot see, and we can see only this part of the environment, also known as the hill of vision, considering its three-dimensional aspect. The apex of the hill of vision is the area with the highest retinal sensitivity. Here you can see the apex, and represents the fovea. The sensitivity decreases as we move to the periphery of the retina. Here you can see to the nasal, it's decrease abruptly. Now the extent of unilocular visual field, it was given by Thomas Young. This consists of central 30-degree field, and extend at 60 degrees superiorly, as you can see, and medially 60 degree. The temporal extension is up to 100 degrees, and inferior extent is up to 80 degrees or 70 in some books. So binocular visual field extends temporally to 200 degrees binocular, with a central overlap of 120 degrees. Marriott was the first one to report the physiological blind spot corresponding to the location of the optic disc. So this is a blind spot. It corresponds to the location of the optic disc. This is optic disc. Here you can see this is the blind spot. The blind spot is located 10 to 20 degrees temporal to the point of fixation. So here is a short history of visual field measurement. The history of visual field analysis dates back to 2000 years, when Hippocrates first reported a case of hemianopsia. Successively, the Almas was the first to publish the first illustration of visual fields. Von Graff was the first one to publish visual field defects that are characteristic of glaucoma as known today. However, he attributed the field defects at that time to amblyopia due to lack of knowledge about glaucoma. Then the Landsberg was the first to describe the arcuate defect of glaucoma. The field defects corresponding to the arcuate-like arrangement of the axons emerging from the optic disc. Then the Germ used a tangent screen. This is a tangent screen to map the details of the central 30-degree diameter of the visual field. In subsequent years, then Goldman developed a Powell parameter. Here you can see that provided a uniform background illumination and a moving optical projection system that could superimpose bright stimuli on the background. Then later on, the Franz Brancasser, Dr. John and Dr. Lynn George Tate were the first one to automate the process of perimetry. Now, measurement of visual field or perimetry. The measurement of the retina's sensitivity to light is shown at a given location in the visual field printout. So, visual field printout tell us the measurement of the retina's sensitivity to light at a given location. The sensitivity of the retina of a healthy individual is highest at the fovea and then reduces towards the periphery. Now the intensity of the light stimulus is measured in a postilb. Postilb is the intensity of the light stimulus. However, a postilb and retinal sensitivity are both are inverse to each other, inversely proportional. Also, the human eye responds to a wide range of a postilb. Therefore, the sensitivity to light is measured in decibel, 0 to 50 in standard automated perimetry. Decibel is the logarithmic representation of the intensity of the light stimulus. It has a direct correlation to the sensitivity of the retina. 0 decibel represents the brightest light stimulus. 0 decibel, brightest light stimulus. And 50 decibel represent the dimmest light stimulus. So a 0 decibel stimulus will be visible. This is the 0 decibel. It will be visible to a point on the retina with the lowest sensitivity, and vice versa. And 50 will be visible to the highest sensitivity. Now the decibel value is relative, so it varies from machine to machine. A 0 decibel reading represents 10,000 apostilbs on the Humphrey visual field analyzer. 0 corresponds to 10,000 apostilbs on the Humphrey visual field analyzer, where it represents 4,000 apostilbs on the octopus. A 40 decibel reading represents 1 apostilb. 40 decibel is equal to 1 apostilb on the Humphrey visual analyzer, where it represents 0.4 apostilb on the octopus perimetry. So 50 decibels is the dimmest target the perimeter can project. It is unlikely that any normal person can detect this dim stimulus. A young and perimetrically experienced person can probably see the 40 decibel target, and that too at the fovea. On the other end of the scale, 0 decibel is the brightest illumination the perimeter can project. Essentially, the ability to identify a 35 decibel target indicates a better sensitivity of the retina, that a point which can identify a 25 decibel target. So 35 decibel target indicates a better sensitivity than a point which can identify 25 decibel target, and this is more sensitive than another point that can identify only a 10 decibel target. In other words, the lower the decibel value, the lower the sensitivity. The higher the decibel value, the higher the sensitivity. Next is threshold. It is the intensity of the light stimulus which, when presented at a particular location, n number of times is detected by the corresponding retinal point at least 50% of the time. Threshold is measured by using the staircase method 4 to 1. Staircase method 4 to 1. There can be two ways to use this method. If the initial stimulus is not seen, then the intensity of the stimulus is increased by 4 decibel until it is seen. Once it is visible, the intensity is reduced by 2 decibel steps till it is again not visible. So increased by 4, decreased by 2. Increase by 4 until it is seen. Decrease by 2 till it is again not visible. Then the intensity is increased by 1 decibel till again it is visualized. This final decibel reading is the threshold. So this will be the threshold. Increase by 1 until it is visible. So if the threshold at each retinal point was evaluated in 1 decibel steps, so if we evaluate in 1 decibel step, it would take a lot of time and the process will tire out the patient easily. Therefore, the staircase method is used. Then we have kinetic perimetry. Kinetic perimetry, the test is actively performed by the examiner where they move the target. Here you can see the examiner move the target on the arc. This is the arc. And this is the patient. He responds by localizing the target. The patient responds by localizing the target when it enters the visual field of the patient. In this test, the intensity of the target remains the same throughout the test, whereas the color or the size of the stimulus can vary. So this test is useful in assessing the two-dimensional extent of the visual field. The commonly used kinetic perimeter is the Goldman perimeter. Static perimetry. This test is automated. The machine presents a stimulus of a particular size but with varying intensity at various locations in a bowel perimeter. The patient responds by presenting a button when they visualize the particular stimulus. The size is constant for one particular test but can be changed between tests. This test measures the depth of the defect at various locations in the visual field. The commonly used static perimeters are the Humphrey and the octopus. Another one is oculus. Kinetic perimetry can also be done by confrontation method, tangent screen, Lister perimetry, Campimetry, and Goldman perimetry. Strategy, these are the testing algorithms used so that the test does not take too much time. The results are not affected by the patient fatigue. For example, the full threshold strategy, the SITA strategy. SITA means Swedish Interactive Threshold Algorithm, and the SITA fast are the different strategies available on Humphrey. Next is program. To reduce the time taken for the test and to enable the patient to carry out a test more attentively, a limited number of points on the retina are checked for their retinal sensitivity. The location and the pattern of the points tested on the retina are decided by the different programs available on the machine. For example, there are different programs are 32, 24-2, 10-2, and the macular program are available in the Humphrey Field Analyzer HFA. So what is 32? The 32 tests the central 30 degree of the retina with fovea as fixation. So this is the 32. This is the fovea. This gives a round printout with 30 degrees around the fovea. The radius of the field is 30 degrees. The digit 2 in this test denotes that the points are not located exactly on the vertical or horizontal midline. The points are not located on the vertical or horizontal midline. Points are located at the midline in the 31 test in the HFA1 machine. Instead, the points are equidistant from this line. Here you can see the points are equidistant from this line. This helps to better document the visual fields obeying the horizontal midline in glaucoma and vertical midline in the visual pathways lesion. A total of 76 points are tested on the retina. with each point at a distance of 6 degrees from the other in the 32 test. So between 2 points are the 6 degrees. This leaves a bare area between the points. This bare area is a circle with a radius of 3 degrees between any 4 points. For example, these are 4 points. So this bare area is a circle with a radius of 3 degrees between any 4 points. This bare area remains unevaluated. Next is 24-2 visual field. This test is a subset of 32 where the outermost points are eliminated. Remaining two nasal points are remained to look for nasal stips in glaucoma. It tests 54 points. This is 24-2 visual field. In the nasal, 2 points are left to check for nasal steps in glaucoma. It tests 54 points, and this may be a better program for the elderly as it reduces the time taken for the test. It also reduces the number of false negatives due to the patient's fatigue, as the outer points are the last ones to be tested. Also, the points eliminated from the 32 field are not considered when diagnosing glaucoma. The distance between any 2 points remains 6 degrees. Now, because the distance between 2 points is 6 degrees, paracentral scotomas can be missed on 24-2 or 32 program. Therefore, any defect close to fixation on these programs should be retested with a 10-2 program. This is a 10-2 program. The 10-2 provides a higher resolution and therefore highlights these defects. A new program 24-2C has been recently introduced in the Humphrey field analyzer. Additional points have been added to the 24-2 program within the central 10 degrees to be able to detect the paracentral scotomas. However, the resolution of the 10-2 is not achieved. The 10-2 tests the central 10 degrees of the retina. It consists of 68 closely placed points with a distance of 2 degrees between any 2 points. This means that a circle with a radius of 1 degree is the area of the retina that remains unevaluated between any 4 points. Glaucoma hemifield analysis is not done during this program, and the visual field index is also not calculated during this program. Thus, the number of points tested in various programs on the Humphrey visual field are 68 points in 10-2, 54 points in 24-2, and 76 points in 32. 76, 54, 68. The macular program is the central 16 points of 10-2. The central 16 points of 10-2. The points in the macular program are tested twice, and this is depicted as a second numeral in brackets below the points tested. Now, indications. Visual field testing is practical in various clinical scenarios. Number 1, diagnosis and progression of glaucoma. Assessment of neurological conditions concerning the visual pathways. Number 3, documentation of field defect and assessment of progression in the retinal disease like retinitis pigmentosa and inflammatory conditions like birdshot chorioretinopathy. Number 4, part of the visual disability certificate or driver license. Number 5, the legal definition of blindness. Number 6, evaluation of unexplained visual loss. Normal and critical finding. How to interpret automated perimetry. The automated perimetry report by the Humphrey can be divided into 8 zones for ease of understanding. This figure shows the 8 zones. 1, 2, 3, 4, 5, 6, 7, 8. Now this is zone 1. This section consists of patient's information like the patient name, date of birth, visual acuity, refractive correction. The refractive correction used for the patient for doing the test, and the patient pupil size. So this is the name, this is the pupil diameter, the date and time, this is the age, and the eye, it shows the left eye. The date of birth should be accurately entered, otherwise the patient data will be compared to the normative database of the wrong eye group. The patient pupil size should be at least 2.5 or 3 mm, or the same as in the previous field test. It also gives information about the test pattern performed, like 32 threshold test or 24-2. The strategy used like CETA standard and CETA fast, and the fixation target used. It is essential to use the recent most refractive correction of the patient with the appropriate near addition when performing the test. If possible, the refraction can be checked the same day before performing the perimetry. It is better to use the built-in trial lens calculator to calculate the power of the trial lens to be placed in the trial lens frame while performing the test. This is because the power of the trial lens will not be the same as the actual spectacle correction of the patient. Conditions requiring a complete near addition of 3 diopter include elderly individuals with an age of more than 60 degrees, pseudopachic or aphakic individuals, individuals with dilated pupils, and individuals of myopia of more than 3 diopters. Refractive error of even one diopter causes generalized depression and sensitivity, which may become a cause for misdiagnosis. The fixation target may be a central dot, which is the default target for Humphrey visual field analyzer. This is central. Or a large diamond that is present below the central dot. The larger diamond is used for patient with a large central scotoma. Small diamond fixation target within the large diamond is also used for evaluating the foveal threshold. This is the strategy used. And this is the refractive correction. The zone 2. The zone mentions the foveal threshold and the reliability indices. The foveal threshold should correspond to the visual acuity of the patient. A good visual acuity with a less foveal threshold would indicate damage to the fovea, and a poor visual acuity with a good foveal threshold would indicate a refractive error that has not been corrected before performing the test. So this is the foveal threshold. It corresponds to the visual acuity of the patient, and a good visual acuity with a less foveal threshold would indicate damage to the fovea. Reliability indices like fixation losses, false positive, these are false positives, false negatives, are also mentioned in this zone. Fixation losses are calculated using the Hazel-Krakow method. The patient is supposed to maintain a fixation at the fixation target during the complete duration of the test, which means that the location of the blind test should remain constant throughout the test. After localizing the blind spot once in the test, the machine randomly presents a stimulus to that point later on during the test. The response to this stimulus would mean that the patient has moved the fixation. This is measured as fixation loss. The machine checks this multiple times during the test. The presence of more than 20% fixation losses indicates poor reliability of the field report per the manufacturer. However, before looking at the fixation losses, the location of the blind spot should be confirmed on the printout. The other two methods of fixation monitoring are gaze tracking and video monitoring of fixation. The gaze tracker is printed at the bottom of the report. The upward deflection denotes eye movement and the downward graph tracing indicate a blink. This tracks eye movement throughout the test, and the examiner can instruct the patient to refixate upon noticing this tracing. The video eye monitor displays the eye of the patient on the monitor of the machine. It is also a good tool for observant examiner. The examiner can instruct the patient to focus on noticing any screen movement. False positives. They are recorded when the patient responds without a presented stimulus. False positives up to 33% are acceptable as per the manufacturer. Excess false positive mask the underlying visual field defects. False negative. They are recorded when the patient does not respond to a stimulus of higher intensity presented at the same location where previously the patient has responded to a lower intensity stimulus. False negative of more than 33% suggest poor reliability of the fields as per manufacturer. False negative affect the reliability less than false positive. A value of more than 35% in advanced disease and more than 25% in early disease may affect the reliability significantly. Now this is zone 3, the grayscale graph. It's a color-coded representation of the retinal sensitivity of the patient. It is not used for the final interpretation of the field test but is important for patient education. The value closer to 0 dB are illustrated as black points of varying shades, whereas a point close to 50 dB are illustrated as white. Points with sensitivity greater than 40 dB are seen as white scotomas on the grayscale and require careful interpretation. They usually indicate a trigger-happy patient who has responded without seeing the stimulus, for example, false positive. The grayscale is useful when comparing the fields of a patient on follow-up. It indicates the progression of the visual field both in extent and in depth over time at a glance, given the reliability indices are within normal limits. Now zone 4. This zone comprises the total deviation numerical plot and the total deviation probability plot. Total deviation numerical plot indicates the depth of field of defect. It compares the dB value of the patient at all retinal points tested to the normative data stored in the machine for that particular age. A normative database is calculated by collecting responses from a group of healthy subjects. The upper 95% of these values are arbitrarily taken as normal and the lower 5% are considered abnormal. This comparison gives the amount of deviation of the retinal sensitivity from normal at each point tested. 0 on a total deviation numerical plot indicates no deviation from normal. A negative value indicates a decrease in retinal sensitivity. These are negative values. A negative value indicates a decrease in retinal sensitivity, with higher negative values indicating a worse retinal sensitivity. A numerical with no sign on the total deviation numerical plot indicates better retinal sensitivity. Since the lower 5% of the data collected from the normal population is considered abnormal, all the abnormal data on this printout does not imply a disease state. Numerical in the total deviation numerical plot are statistically analyzed and represented as a total deviation probability plot. The probability plot is color coded with light. Now in this figure 6, the yellow line is the expected normal hill of vision in normal of the same age as the patient. The shaded area is the depression of the patient hill of vision. The total deviation plot highlights this deviation. So this is total deviation plot. In other words, the total deviation plot draws our attention to any overall sinking of the hill of vision. This overall sinking of the hill is usually caused by media opacity such as cataracts, corneal opacity, refractive errors, meiosis. Rarely this can be the sole manifestation of glaucoma. The shaded area in the total deviation plot highlights in overall sinking of the patient vision as compared to age-related normal. It is depicted as both numerical plot and probability plot. Probability plots predicts the chances of such as abnormality occurring in normal population. The black dots indicate less than 0.5% of normal population would be expected to have such a depression in those areas. Total deviation plot also highlights any scotomas that may be present involving a large area of the visual field. Zone 5. To produce this zone, the machine adjusts for overall depression of the visual field due to cataract or some other reason. It adjusts for any overall sinking of the hill of vision and in the pattern deviation plot. It draws our attention to any localized scotomas that may have been hidden inside this depressed visual field. The pattern deviation plot is also provided as a numerical plot as well as a probability plot. We generally look at the probability plot. We try to look for abnormal points in a cluster. The low probability symbols don't matter as much as abnormal points in a cluster in an expected area. So zone 5 comprises pattern deviation numerical plot and pattern deviation probability plot. These demonstrate the presence of localized field effects in their pattern. To calculate numerical values of the pattern deviation numerical plot, so the values on the total numerical plot are chronologically arranged and the 7th best point on this data is noted. An amount in the range of this value is deducted from all the values on the total deviation numerical plot. So an amount in the range of this value is deducted from all the values in the total deviation numerical plot. This gives the pattern deviation plot corrected for generalized depression in retinal sensitivity to highlight an underlying localized depression in the field. Generalized decrease in retinal sensitivity would mean a uniform decrease in the height of the hill of vision compared to a normative database. Zone 6. This zone consists of global indices, which are the mean deviation, pattern standard deviation in the visual field index, and the p-value. The mean deviation, it is the average of all the values of the total deviation numerical plot. It usually has a negative value. Generalized field defects or advanced glaucoma will have a higher absolute mean deviation index. Localized field defects are however masked and have a low mean deviation index. Positive mean deviation index should be evaluated with a caution, as that would mean a higher than normal retinal sensitivity. False positives should be assessed in these cases. Next is PST, pattern standard deviation. This indicates a deviation in the shape of the hill of vision. It has a positive sign. A low value indicates a normal shape of the hill of vision. A higher value indicates irregular hill of vision. It has a useful index to diagnose cases with early glaucoma. In patients with advanced field defects, the shape of the hill of vision has a deviated overall, so the PST value is low. Hence, this indicator loses its value. This indicator loses its value in patients with advanced field defects. This index is known as loss variance in the octopus machine. Short-term SF, short-term fluctuations. This is a feature of a field test using the full threshold strategy. Selective 10 retinal points are checked for threshold twice. The variability in the threshold value is indicated as SF. A value of more than 3 indicates low reliability. CPSD, corrected pattern standard deviation. This is the PSD value achieved after correcting for SF. Zone 7. This consists of glaucoma hemifield test (GHT). Glaucoma affects the retinal ganglion cells on either side of the horizontal meridian. Therefore, 5 areas with a set of retinal points in each area are tested on both sides of the horizontal meridian and compared. The results are displayed as GHT within normal limits, GHT borderline, or GHT outside normal limits. Zone 8. It is the raw data collected by the machine and consists of the retinal sensitivity and decibel values of each point tested for that program. Absolute scotoma is indicated by 0 dB value. Confirmation of glaucoma field defect. There are 3 criteria by which we could label a field defect as early glaucoma. Criteria 1. First, in the pattern deviation plot, if it is a 32 program testing out 30 degrees, one has to ignore the outside edge points. This is not needed in 24-2 program. Then let us see if there are 3 or more non-edge points that are depressed. So check for 3 or more non-edge points that are depressed to an extent that would be found in less than 5% of the population. One of those points should be depressed to an extent found expected in 1% of the population. These points should be clustered in the arcuate area. So in this figure, one can see there are more than 3 such points. So one can see there are more than 3 such points in the pattern deviation plot, and all of them are depressed to an extent that has been expected in less than 0.5% of the population. So this is criteria 1. Criteria 2. The corrected pattern standard deviation, or the PSD, should be depressed to an extent found in less than 5% of the population. So in this figure, CPSD is depressed to an extent found less than 0.5% of the population. Criteria 3. The glaucoma hemifield test is outside normal limits. This is outside normal limits. So there are 3 criteria by which we could say a field is glaucomatous or not. So do we always need all 3 criteria to establish a diagnosis of glaucoma? Can we rely on one positive criteria? This depends upon the testing situation. If one wants to detect all the glaucomas and is not unhappy dealing with false positive, then even one positive criteria will suffice. On the other hand, if one willing to miss very early glaucoma but wishes to minimize the false positive, then all 3 criteria must be positive before considering diagnosis of glaucoma. In figure 10, all 3 criteria are fulfilled. In the clinical context, if the clinical features strongly indicate glaucoma, such as raised IOP and suspicious disc with glaucomatous features, even one criteria is good enough to make a diagnosis. On the other hand, if the clinical features are not suspicious at all, normal IOP, healthy neuroretinal rim that maintain the is not rule, all 3 criteria must be positive before one even begins to consider a diagnosis. Also, we would repeat the field and go back and to look at clinical features, especially the disc, before making a diagnosis.